Assalamu alaikum. Oral ulcers are very common. A USA study showed that the point prevalence is about 4% of the general population. In this presentation, we shall go through more than 40 different types of oral ulcers and use a very simple diagnostic algorithm in order to help in differentiating the diagnosis. Of the more than 40 different types of oral ulcers that we shall go through in this presentation, most are benign and self-limiting and will resolve within 2 weeks. But some are recurrent and some may persist longer than 2 weeks, and some are sinister and may be malignant or a manifestation of a life-threatening condition that has to be treated urgently. We obviously need a roadmap to navigate our way to the diagnosis, and the suggested algorithm is one such roadmap. Depends on few steps to reach the category that you want to differentiate the diagnosis from. The first step is whether the condition has been there for less than 2 weeks, acute, or more than 2 weeks, chronic, or have been there before, recurrent. I'll start with the acute, and the second step is to determine whether the ulcer is solitary. In this case, it can be either traumatic or necrotizing sialometaplasia, or multiple, and in this case you have 4 different categories. One of them preceded by a prodroma like fever and malaise. The other is associated with dermatology disorders and skin conditions, or if you have reasons to suspect oral allergy or hypersensitivity or disturbance of the immunity. And the fourth is associated with dental conditions. If it is associated multiple acute ulcers associated with a prodroma, it's usually viral in origin, either Herpes Simplex, Herpes Zoster, Herpangina, or hand and foot and mouth disease. If it is associated with skin conditions, it may be Erythema multiforme, for example. And if it is, you have reason to suspect allergy, consider plasma cell stomatitis. And in the dental associated problems, it may be a necrotizing ulcerative gingivitis. Acute traumatic ulcers are among the most common oral cavity ulcerations. They affect mostly the buccal mucosa, followed by the tongue and occasionally the lower lip. They affect males more than females. In the adults, they can be caused by mechanical damage, like from a ragged tooth or from an ill-fitted dentures, or by thermal or chemical burns. In the newlyborns, they are usually in sublingual area, and they are caused by a premature eruption or decidual teeth in the natal or the neonatal period. In children, it's mostly thermal injury in the lips. The borders of the ulcer are sometimes raised and reddish, or it can be whitish and hyperkeratotic. The base of the ulcer is yellowish white, necrotic, and covered by a pseudomembrane that can be readily wiped off. The ulcer stops to be painful within 3 days, but they may take as long as 10 days to heal. Usually the tongue ulcers would take a bit longer to heal. Chemical and thermal trauma can also cause oral ulceration. The habit of placing an aspirin pill over a painful tooth can cause an acid burn to the mucosa. The ulcer will be painful, it will be deep and punched out with little inflammatory halo or reaction and no induration. The second cause for acute and solitary oral ulcers is necrotizing sialometaplasia. This is probably an infarction due to ischemia of the minor salivary tissue distributed within the oral cavity. It affects more middle-aged men, and the predisposing factor is usually a direct local injury, like, for example, injection with a needle in dental work, and even finger manipulation of the palate to induce vomiting in bulimic patients. It affects anywhere in the oral cavity that has some salivary tissue, but more than 75% of these ulcers would be in the palate, followed by the lower lip and retromolar area, sometimes the sublingual area as well, or even the larynx. They can be as big as 5 centimeters. The edge of the ulcer is indurated and has a crater-like type, well delineated borders. They start to heal within 10 days, but they may take up to 6 or 7 weeks to heal completely. We now move to multiple oral ulcers, and by far the commonest cause for multiple oral ulcers are viral infections. They have some common features. They are multiple, small, and symmetrical ulcers, but sometimes they coalesce to form larger lesions with scalloped borders. Most infections in the mouth are caused by them, particularly in a child or a young adult, and is usually preceded by a prodroma of fever and malaise and cervical lymphadenopathy. Several viruses can cause ulcers in the mouth. The most important are the Herpes Simplex, causing primary herpetic stomatitis. About 1/3 of these herpetic stomatitis can be recurrent. If the infection is unilateral, it is usually due to Herpes Zoster infection, and the enterovirus group can cause the Herpangina that causes posterior oral cavity and oropharyngeal ulcers, or the hand, foot, and mouth disease, which can cause ulcers in the front part of the oral cavity. Other viruses can also cause infection in the mouth, including chickenpox and infectious mononucleosis as well. By far, the commonest virus that causes ulcerative stomatitis is Herpes simplex, giving rise to primary herpetic gingiva stomatitis. It affects both the keratinized and the non-keratinized mucosa of the mouth, as opposed to, for example, the Aphthous ulcers, which mainly affects the non-keratinized mucosa. It affects young children from the age of 6 months up to 5 years or more, with a peak prevalence between 2 and 3 years. It starts with fever, nausea, anorexia, and irritability in the child, with generalized gingivitis, and followed by, within 2 to 3 days, by pin-headed vesicles. These vesicles will readily rupture to leave about a small painful ulcer with a necrotic base. Some of these ulcers can coalesce to form a larger ulcer with a scalloped edge. Here they affect the tongue or the lips, and they can have this scalloped border with a erythematous halo around the border of the ulcer. They are associated with lymphadenopathy, halitosis, and difficulty in swallowing, but they usually self-resolve within a week and leaves no scarring. 90% of the herpes simplex infection are caused by the type 1 virus, and the remaining by the type 2 herpes simplex virus. Another viral stomatitis is caused by the Herpes Zoster infection, giving rise to shingles. This is caused by reactivation of the varicella zoster virus, particularly as a result of immune system deficiency. Sometimes it can happen spontaneously in the elderly. It affects mostly the hard palate, the gingiva, or the tongue, and is usually preceded by unilateral pain prodroma. The ulcers, the vesicles form first along the course of a nerve, in this case along the greater palatine nerve. They readily rupture to cause small ulcers that may coalesce to form a larger scalloped edge unilateral ulcers. This is the main distinguishing feature, is that they are unilateral. They are self-limiting and they heal within less than 2 weeks. A third condition of viral stomatitis is Herpangina,
caused mainly by the enteroviruses group, particularly Coxsackie virus A and B and the echovirus. They affect children under 10 years of age. They give sudden rise to pharyngeal pain, fever, and multiple ulcers again in the posterior part of the oral cavity and in the oropharynx, mainly the palate and the throat. They start with vesicles and then ulcers forms after the rupture of these vesicles in the oropharynx and the palate and sometimes in the tonsillar area as well. It is self-limiting and the management is directed mainly towards pain control and good hydration and mouth hygiene. The Coxsackie A virus can cause another type of stomatitis, the hand, foot and mouth disease, associated with skin problems in the hands and the feet, together with vesicles in the front of the mouth rather than the back of the mouth, like in Herpangina. Here you would have vesicles followed by ulcers in the palate or sometimes also in the tongue. The ulcers are again self-limiting and the management is supportive with pain control and good hydration and mouth hygiene. Another example of bacterial infection that causes multiple oral ulcers is the Reiter syndrome that cause ulcers on the palate and the tongue and the lips, superficial small ulcers. They have usually a history of bacterial gastroenteritis, and the patient will also have urethritis and inflammation of the conjunctiva and arthritis as well. We now move to multiple oral ulcers associated with dental condition, necrotizing ulcerative gingivitis. This will cause multiple ulcers in the interdental papillae or the gingival margins. They are caused by bacterial infection with predisposed conditions in the gingiva, including smoking, poor oral hygiene, gingivitis, malnutrition, psychological stress, or HIV infection. They give rise to severe pain in the gingiva. They also give rise to halitosis and bleeding from the gums. The ulcers are punched out. Ulcers with a crater and have a necrotic base. Medications can cause sometimes oral ulcerations in different ways. We have seen examples of oral ulcers caused by acoustic burns, like in aspirin, for example. Some medications can cause drug allergy and give rise to conditions like erythema multiforme or lichenoid eruption. Also, some medications like cytotoxic drugs can have direct effect on the rapidly dividing cells and can cause bone marrow suppression and oral ulceration. Multiple oral ulceration can also be caused by allergic reactions or hypersensitivity. Plasma cell stomatitis is an example of contact stomatitis that can be caused few days after exposure to certain antigens. They mainly affect the gingivae, the buccal mucosa, and the buccal sulcus, and they cause multiple shallow ulcers. They start with erythematous macules of the gingivae, some desquamation of the gingiva, desquamative gingivitis with epithelial sloughing, and superficial multiple ulcers of the gingiva. And they are self-limiting, but the use of anti-inflammatory agents can help in diminishing the healing time, and also patients would require pain control. Lichenoid eruption is an example of a hypersensitivity reaction to certain medications. Here the agent was a beta blocker that caused a central necrosis, but peripheral reticular, a white stria coming out from the central necrosis. The ulcer would be painful, but it would resolve completely after stopping the medication. The medications that can cause oral ulceration in the form of lichenoid eruption includes things like antimalarial drugs, antihypertensives, beta blockers, Antimicrobials like tetracycline, non-steroidal anti-inflammatory drugs, aspirin and naproxen, oral hypoglycemics, and other drugs including, for example, lithium and lorazepam. Erythema multiforme is an acute hypersensitivity reaction with mucocutaneous manifestations. They are triggered by either some medications, including things like cephalosporins, quinolones, analgesics, and non-steroidal anti-inflammatories, and penicillins, and sulfonamides, or several infections, mainly herpes simplex virus and Epstein-Barr virus, cytomegalovirus, and varicella zoster, and others. The skin lesions characteristically are formed of target lesions. They look like targets. Target lesions are formed of red macules, so papules and vesicles that coalesce to form larger plaques and form these target lesions. They are diagnostic. In the oral cavity, they mainly affect the lips and the buccal mucosa. Again, they are formed of red erythematous macules, followed by formation of bullae, and these bullae would rupture and form large ulcers. These ulcers may coalesce to form larger scalloped edges, big ulcers on the lip or the buccal mucosa. The diagnostic feature is blood incrustations over the lips. This is diagnostic. Erythema multiforme has a slight male predominance. It affects more the age group between 20 and 40 years and affects mostly the lips and the buccal cavity and the tongue. It forms large and confluent ulcers, multiple ulcers. They often are mixed with conditions like herpetic gingival stomatitis, but the ulcers here are much larger. They can be preceded by prodromal symptoms in the form of fever, headache, lymphadenopathy, and sore throat, and these prodroma may be noticed a week before the start of the eruption in the skin and the mucous membrane. Erythema multiforme can be graded according to the severity of the condition into minor, major, or Stevens-Johnson syndrome, or even toxic epidermal necrolysis 10 syndrome. In Stevens-Johnson syndrome, the skin detachment, the bullae formation after skin detachment, cover less than 10% of the body surface area. In the toxic epidermal necrolysis, it's more than 30% of the skin surface area. Patients with these two conditions have high risk of sepsis and septic shock due to Staph aureus and Pseudomonas aeruginosa infection. These can cause sometimes death in severe cases. Chemotherapy and radiation therapy can cause multiple acute oral ulcers. Just less than half of the patients who undergoing chemotherapy will develop oral ulcer lesions. These will be multiple, affecting any site within the oral cavity. They are asymmetrical, some are small, some are large, and they have some erythematous areas as well, and they would probably start within a week from the start of the chemotherapy and would resolve after completion of the chemotherapy treatment. Mucosal damage is the most common acute side effect of radiation therapy as well. Again, it presents as erythema and mucosal atrophy, but can also cause ulceration with or without pseudomembranes on top of it.
We now move to the second group of oral ulcers. These are the recurrent oral ulcers. This second group of oral ulcers had 4 common etiologies and 4 less common etiologies. The common etiologies include the Aphthous ulcers, the herpes ulcers, either the Herpes Simplex or the Herpes Zoster, the traumatic ulcers again, and again the oral allergy or hypersensitivity ulcers. These are the 4 common groups of recurrent ulcers, and they have quite distinct clinical manifestations. The less common groups include the Behcet's disease, the cyclic neutropenia, the Reiter syndrome that we have been through, and the herpes-associated erythema multiforme.
Recurrent Aphthous stomatitis is fairly common. In a USA study, more than 50% of healthy students had positive history of recurrent Aphthous stomatitis. There is a female predilection. The first episode of aphthous ulceration usually occurs in the second decade of life. It affects mostly the non-keratinized mucosa of the oral cavity in healthy subjects, including the buccal mucosa, the oral vestibule mucosa, the undersurface of the tongue, and the floor of the mouth. But it may also affect the keratinized part of the keratinized mucosa of the oral cavity in patients who have some immune deficiency. Aphthous stomatitis starts with a prodroma of a burning sensation that lasts for few hours up to 48 hours before the ulcer actually appears. When the ulcer appears, it's painful. There are usually multiple ulcers, symmetrical, of almost the same size, round or ovoid, and are yellowish white in color. They are surrounded by an erythematous halo. The predisposing factors include things like familial tendency, local mouth trauma or stress. Some patients may be sensitive to other agents, including, for example, sodium lauryl sulfate, and they would respond to SLS-free toothpaste. Ulcers can be classified into minor, major, and herpetiform. The minor aphthous ulcers were first described in 1898, and they are by far the commonest of the three types of aphthous ulcers, accounting for about 80 to 90% of all the aphthous ulcers. They would measure less than 5 millimeters in diameter, usually between 2 and 3 millimeters, and at any one time a subject could get as many as 6 of them at the same time. They typically heal spontaneously within 10 days or so. Aphthous-like ulcers can occur in other systemic diseases such as inflammatory bowel disease, celiac disease, and nutritional deficiencies, immunoglobulin A deficiency, Magic syndrome, the mouth and genital ulcers with inflamed cartilage disease. They can also occur in association with the use of certain medications, including non-steroidal anti-inflammatory drugs. Major aphthous ulcers were described a bit later in 1911. They would account for about 10% of all recurrent aphthous ulcers. They are bigger in size, measuring 1 to 3 centimeters. They are also deeper and would take longer to heal, up to 6 weeks or even more. And when they heal, they can heal with scar tissue in contrast to the minor aphthous ulcers. Sometimes the major aphthous ulcers could affect keratinized as well as non-keratinized areas of the oral cavity, including the dorsum of the tongue and the palate as well. They can be associated with considerable pain and malaise and difficulty in swallowing. Laboratory evaluation would be required if the episodes become very severe and if the lesions begin to show after the age of 25 years or when there are general symptoms accompanying the lesions like fever and malaise and lymphadenopathies. The herpetiform type of aphthous ulcers account for about 10% of the recurrent aphthous ulcers, and they are very small, tiny ulcers measuring about 1 to 2 millimeters, but they come in quite substantial numbers, sometimes up to 100 lesions at the same time. They cluster into a same area, resembling very much the type of ulcers associated with viral infections, hence the name. They can be very painful. They may fuse together to form a larger ulcer with a scalloped edge, as seen in viral infections, and about a third of them would heal with scar tissue. Another cause for recurrent oral ulcers is the repetitive traumatic oral ulcers, the bite injuries, seen for example, in the autism spectrum disorder subjects, or patients who have intellectual disabilities, or in the context of a seizure. It can also be induced by ill-fitting dental braces or aggressive tooth brushing or a damaged tooth enamel or deformation of the tongue. Sometimes also bruxism can induce recurrent oral ulcers. Behcet's disease is a systemic immune-mediated vasculitis characterized by recurrent oral and genital ulcers, ocular inflammation, and skin lesions. Affect mostly the age between 25 and 40 years. It's rare to affect subjects before puberty or after their 6th decade of life. It affects males and females equally. It forms Aphthous-like ulcers, more similar to the major type of Aphthous stomatitis, affecting the oral cavity and the pharynx. The recurrent and painful oral ulcers are present in more than 90% of the subjects presenting with Behcet's disease. Oral and genital ulcerations is not restricted to Behcet's syndrome or variants such as the MAGIC syndrome, the mouth and genital ulcers with inflamed cartilage. Other systemic mucocutaneous disorders could present in the same way. The pathology test was at one point thought to be a diagnostic feature of Behcet's disease. It is a hyperreactivity to intradermal needle prick. It was tried in several places, including Turkey and Japan, and was found useful, but apparently the British patients almost invariably give a negative result to the intradermal needle prick test. Diagnosis of Behcet's disease can be based on recurrence of Aphthous-like ulcers at least 3 times within a year. These ulcers would be more like the major type of Aphthous ulcers, large ulcers, deeper and with longer duration. They are also more tender. Along with 2 other manifestations of the following, either genital ulcers, ocular lesions in the form of uveitis, either anterior or posterior, and vitreous cellularity, or retinal vasculitis, or skin lesions like erythema nodosum or pseudofolliculitis, for example, in a post-adolescent patient without any steroid treatment. The international criteria for Behcet's disease came up with a scoring system, and diagnosis the disease would depend on obtaining 3 points from the following: 2 points if there is genital ulcers or eye lesions each, and 1 point if there is skin lesions or oral aphthous or vascular lesions. Cyclic neutropenia is another cause of recurrent oral ulcers. This is an immunodeficiency syndrome characterized by irregular and periodic oscillation in the numbers of circulating neutrophil. These levels will drop every 21 days and last for 3 to 6 days in the reduced numbers. This is usually asymptomatic, but sometimes during the phases when the neutrophils drop, there may be an episode of fever of unknown origin, gingivitis, stomatitis, or Aphthous-like ulceration, like a major Aphthous ulceration. They can also have aggressive periodontitis. The condition starts in childhood and affects any oral mucosa that's exposed to trauma. The episodic ulcers have a reddish halo around the ulcer with a concomitant fever, gingival inflammation and recession, and systemic infections like cellulitis or perirectal abscess or severe systemic pyogenic infections elsewhere.
Now, next we'll go through the chronic oral ulcers. We now focus on the third and the last group of oral ulcers, those ulcers that persist for more than 2 weeks, and they can be broadly classified into solitary or multiple ulcers. In the solitary ulcers group, there is the very common traumatic ulcer and the very sinister malignant ulcer. There are also 2 other groups of solitary ulcers related to trauma, Necrotizing Sialometaplasia and eosinophilic ulcer. and a group of ulcers related to specific infections, including TB, syphilis, and deep fungal infections, or granulomatosis, like, for example, ulcers associated with sarcoidosis or polyangiitis granulomatosis, previously termed Wagner's granulomatosis. The multiple ulcers include the very common major Aphthous stomatitis. They persist for more than 2 weeks, and the dermatology-associated oral ulcers, either the lichen planus or the lichenoid eruption that we have been through, or the blistering dermatosis that we shall explore.
Oral carcinoma is the most sinister of all oral ulcers, and its diagnosis has to be categorically excluded as a first step in the management of solitary chronic ulcers. There are some features that would raise suspicion of oral carcinoma and other features that may reduce this suspicion. And the suspicious groups of ulcers are the ulcers that are non-healing and painless. Solitary ulcers present for more than 2 weeks, particularly if there is induration and thickening and rolled edge. A history of smoking and alcohol would also raise the suspicion, particularly in men over the age of 40 or 50 years, and if there is a previous history of diagnosis of a pre-malignant lesions. And in addition, if there is no history of previous ulceration, this is a de novo ulcer in this age group, and when there are no local or systemic factors to explain the ulcer, like no potential cause for local ulcers or systemic conditions. On the other hand, the features that may reduce suspicion include recurrent ulcerations that heals in between the episodes. Multiple ulcers would also reduce the suspicion, particularly if they come in clusters. And if the ulcers are associated with systemic disease, particularly autoimmune disorders, and if there is a history of blistering formation or associated with gingivitis, sore and bleeding gums, and if there is an identifiable local or systemic cause, for example, a sharp tooth. Start with the solitary chronic oral ulcers, with the most sinister of them all, the malignant oral ulcer. 95% of all oral malignancies are ulcerative squamous cell carcinoma. They affect men more, particularly in the age group above 40 years. They have a crater-like, a rolled and indurated border and a velvety base. They can be painless to start with, but if they involve any nerves, they can cause pain or paresthesia. Other presenting symptoms may include things like earache, referred earache, of course, trismus, dysphagia, halitosis, and neck nodes. The most common site would be like this, the lateral border of the tongue. They can also affect the floor of the mouth and the lower lip. They are almost always solitary, but in rare cases they can have a multifocal presentation. Of the other less common sites and presentations include the alveolus. Here you would see a squamous cell carcinoma ulcer in a hyperkeratotic area because of an ill-fitting denture. They can also present like a fungating mass that becomes apparent after dental extraction for a loose tooth. A squamous carcinoma of the gums and the alveoli tend to occur in the molar and the premolar regions, particularly of the lower jaw. Lymph node enlargement can be seen early. In addition to squamous cell carcinoma, there are other malignant causes for oral ulcers, including the non-Hodgkin's extranodal lymphomas, the minor salivary gland tumors. Both the lymphomas and the minor salivary gland tumors commonly present as masses, but can also present as an ulcer. You can also see an extension from a tumor of the maxillary sinus into the upper alveolus, or odontogenic tumors, metastatic neoplasia of the connective tissue of the bone, and neoplasia of the melanocytes. Hepatic ulcers are one of the commonest causes for solitary chronic oral ulcers. They affect more the buccal mucosa. About 40% of them would occur in the buccal mucosa, followed by the tongue, the lateral border of the tongue, or the lower lip. The borders of the ulcer would usually be raised. They can be either reddish or whitish in a hyperkeratotic area. The base of the ulcer is yellowish to white and covered with a pseudomembrane that can be readily wiped off. The ulcers would usually be painful, at least for the first 3 days or so, and gradually the pain would subside and the ulcer may heal within a week or 10 days if the local cause of irritation is removed. They may persist a bit longer if the ulcer is sited over the tongue edge. Another chronic oral ulcer that may be caused by trauma is the eosinophilic ulcer, termed the traumatic ulcerative granuloma with stromal eosinophilia. It affects females more in the age group between 40 and 60 years. It affects mostly the tongue, more than half of the cases, followed by the buccal mucosa and other regions like the retromolar area and the floor of the mouth or the lips. They are almost always solitary. They have a punched out appearance and the border would be rolled and surrounded by either erythema or keratosis, whitish keratosis. They are mostly asymptomatic and there is no much pain. The healing time can vary between very short, like a week or so, up to a year. The main etiology for such ulcers is not very clear, but trauma is elicited in just less than 50% of the cases. The edge of the ulcer is rolled and elevated, and this resembles very much an ulcer of squamous cell carcinoma origin. The ulcer size can range between 5 millimeters to few centimeters. In about 2/3 of the cases, the ulcer would be asymptomatic and persists for few months. And surgical excision is the recommended and accepted form of treatment to rule out malignancy and also to cure the ulceration. Recurrence is very rare. Other forms of management include intralesional steroid injection or topical steroids and antibiotics, or sometimes cryotherapy as well. Following the predisposing factor, which is usually a sharp direct local trauma or an ill-fitting denture or upper respiratory tract infection or even radiotherapy, the initial lesion would be a tender and erythematous nodule, followed by the deep ulceration due to the necrosis and the ischemia of the salivary tissue. The ulcer would have a yellowish base. It resembles a squamous cell carcinoma because of the indurated and rolled border, and it can also resemble mucoepidermoid carcinoma, and if the ulcer persists without healing for a few weeks, it should be biopsied. Now move to a group of solitary chronic ulcers caused by infections, started with the tuberculous oral ulcer. The WHO estimates that TB is still around in the area of several million cases. 1.4% of these cases would have oral ulcers. They affect males more. They are almost always solitary and affect mostly the tongue, followed by the gingiva, but they may affect the floor of the mouth, the palate, the lips, or the buccal mucosa. The characteristic feature is this: the rolled undermined border. This undermined border may be ragged and is often painful. The differential diagnosis include things like traumatic ulcer, syphilitic ulcer, or squamous cell carcinoma ulcer. All are solitary chronic oral ulcers. Syphilis can cause an oral ulceration, the chancre. It's a solitary chronic ulcer caused by the Treponema pallidum about 1 to 3 weeks after the acquisition. It's usually on the lips, particularly the upper lip in males and the lower lip in females, but it can also affect the tongue or the pharynx or even the tonsils. The base of the ulcer is clean and it is red, purple, or brown. The edges are ragged and rolled, and there is usually cervical lymph nodes. Again, the differential diagnoses include things like traumatic ulcers and squamous cell carcinoma ulcers. 80% of the adults would have serological evidence of a previous cytomegalovirus infection. This is usually asymptomatic, but it's in the immunocompromised patients who are receiving immunosuppression or HIV positive patients that manifestations of the infection may be noted. This can be general, like fever or myalgia and lymph nodes in the neck, and also oral ulcerations. The oral ulcers are usually large. They affect the keratinized and the non-keratinized areas, particularly of the palate and also the lips. They are painful and shallow ulcers with minimal rolling of the edge. The base of the ulcer is usually covered by a necrotic slough. The cytomegalovirus may be persistent for a few weeks or few months. The ulcer would heal very slowly. It's usually treated by antiviral agents plus a topical anesthetic and systemic analgesia due to the painful ulcer. And move to oral ulcers caused by a group of fungal infections, deep fungal ulceration, including histoplasmosis, blastomycosis, and mucormycosis. For the first two, there is usually a history of lung disease or dealing with animals. In mucormycosis, there is usually a debilitating disorder such as diabetes or immunocompromised subjects. In the histoplasmosis, there is usually an area of erythema that converts into a granulomatous ulcer, a sort of an ulcer with evidence of granulation tissue around it, warty-like type of ulcer. This is usually associated with pulmonary involvement and can also occur in the disseminated form of the histoplasmosis. The other deep fungal oral ulceration is caused by blastomycosis. It affects men more and can affect any area in the oral cavity, and it's usually a solitary, painless ulcer with irregular and rolled border. It has the appearance of a verrucous mucosal hyperplasia. This is the most frequent feature, a verrucous ulcer with indurated border that's often mistaken for oral squamous cell carcinoma. It usually occurs concomitant with pulmonary lesions, and as seen here in this chest X-ray. Third type of deep fungal infection is the oral mucormycosis ulcers. These would usually affect the palate. They are solitary, large, and deep necrotic ulcer due to invasion of the palatal vessels. They start like a verrucous ulcer, but they have a necrotic appearance as well because of the ischemia induced by the vessel invasion. It's usually concomitant with a pulmonary disease and have an underlying debilitating disorder like diabetes or immunocompromised subjects. There is a group of granulomatosis causing solitary chronic oral ulcers, starting with the granulomatosis with polyangiitis, previously termed the Wegener's granulomatosis. The pathology here is a necrotizing vasculitis plus a granulomatous inflammation. They present as an oral ulcer associated with disorders of the upper respiratory tract infection. The lungs and also the kidneys are involved. The initial lesion would be a painful cobblestone change to the mucosa of the palate. In advanced case, this will cause a palatal perforation like in here. There is the diagnosis would be established with C-ANCA and P-ANCA, but their absence does not necessarily rule out the diagnosis. The treatment is corticosteroids plus cyclophosphamide. The other granulomatosis that can cause a solitary chronic oral ulcer is sarcoidosis. This can give rise to a single superficial ulcer, sometimes combined with nodules and swelling of the buccal mucosa. We move now to multiple chronic oral ulcers, starting with the very common, the major Aphthous stomatitis, and then the group of skin conditions. The common one of them is the oral lichen planus, and the lichenoid eruption as a hypersensitivity to certain agents and medications, followed by the blistering dermatosis, the pemphigus vulgaris, the mucous membrane pemphigoid, the bullous pemphigoid, and the linear IgA disease, and finally the angina bullosa hemorrhagica. Starting with the major Aphthous stomatitis. In fact, the majority of chronic oral ulcers are accounted for by the major Aphthous ulcers. They are different from the much commoner minor Aphthous ulceration in that they can affect keratinized and non-keratinized areas like the dorsum of the tongue or the palate and other sites in the oral cavity. They are also larger and deeper than the minor aphthy. They persist longer, sometimes over 6 weeks, and can leave scar tissue after healing. They can also cause substantial pain and sometimes fever, dysphagia, and malaise. The most common skin disorder to have oral manifestations is the lichen planus. It's a chronic autoimmune mucocutaneous disease that affects females more, particularly the middle-aged. And the prevalence is quite high, and the oral lichen planus could be seen in as much as 2% of all the cases of lichen planus. They have different subtypes with different clinical presentations. Different subtypes of the lichen planus has different clinical presentations. The most common is this, the reticular form with the characteristic Wickham's stria on the buccal mucosa or the tongue, and it's generally asymptomatic. There is also the atrophic form affecting the gingiva and giving rise to desquamative gingivitis. Then the plaque form, this resembles very much hyperkeratosis on the dorsum of the tongue and is more common in smokers. And the erosive or the ulcerative form characterized by a large map-like lesion on the ventral surface of the tongue surrounded by a hyperkeratosis and can be quite painful. Lichen planus is considered a pre-malignant lesion. The risk of malignancy can be as high as 3.7% and can often develop even after 10 years or so. The most frequent sites affected is the buccal mucosa, followed by the tongue, sometimes the gingiva, the palate, and the vermilion border. Pathologically, the lesion would show hyperkeratosis, but also degeneration of the basal cell layer of the epithelium and the presence of subepithelial band of lymphocytes, the so-called interface mucositis. The demonstration of fibrinogen deposition beneath the basement membrane by direct immunofluorescence is diagnostic. For the asymptomatic subtypes of the lichen planus, no treatment is required, but just a good follow-up and perhaps also prolonged follow-up. But for those patients with symptoms like the erosive type, the treatment is usually topical or even systemic corticosteroids. And then there is the group of the blistering dermatosis, the vesiculobullous disease, starting with the pemphigus vulgaris. This is a chronic vesiculobullous mucocutaneous autoimmune disorder. It's acantholytic as the circulating antibodies against the desmosome protein would lead to a loss of cell adhesion, acantholysis, and blister formation. It affects subjects in their 4th or 5th decade of life and affect mostly the buccal mucosa, the palate, or the gingivae. It gives rise to map-like shallow irregular ulcers with peripheral extensions. The ulcers keep extending. The lesion at first is a bulla with a very thin roof that easily ruptures. So It can rarely be seen the bulla intact. The patient usually presents with the ulcer itself. They also have the characteristic positive Necrolysis sign. This basically reflects the ease by which the roof of a lesion can be sloughed off by very mild friction. Some of the patients would have desquamative gingivitis, and 50% of the patients with pemphigus vulgaris, they would have oral manifestations as their first sign of the disease. The edge of the ulcer would continue to extend over a period of weeks until they involve a large area in the oral cavity. Clinically, the patients with pemphigus vulgaris would have these large, shallow ulcers and sometimes desquamative gingivitis. The differential diagnosis would include the other forms of erosive mucosal disease, such as mucous membrane pemphigoid, erosive lichen planus, and erythema multiforme. They can be distinguished by a biopsy to identify the level of separation of the epithelium. This is an acantholytic type of lesion, and also direct immunofluorescence to localize the autoantibodies attached to the tissues in the suprabasal areas of the stratum spinosum. It can usually be treated by systemic steroids, sometimes in high doses, with the addition of steroid-sparing agents like azathioprine. Other agents have been tried as well. A maintenance dose can be monitored by the level of the pemphigus antibody in the serum. Another vesiculobullous disorder, which affects the oral cavity far more common than the pemphigus vulgaris, is the mucous membrane pemphigoid. It's a chronic blistering condition, affects the oral mucosa and also the ocular mucous membrane. It affects mainly mucous membranes in over 90% of the cases, but may also affect the skin in about 20 to 30% of the cases. It affects mostly the gingiva and the buccal mucosa and can give rise to desquamative gingivitis, like in here. It has a female predilection, particularly in the 5th and the 6th decades of life. In contrast to pemphigus vulgaris, the blisters are not as fragile as those of the pemphigus vulgaris, and can sometimes the patient present with intact bullae. The lesions are mainly on the gingiva, and sometimes they can have eye lesions as well, with frequent scarring of the canthus or the cornea or the eyelashes, giving rise to entropion, and can sometimes be complicated by visual problems. The diagnosis would be established by a biopsy, which would show that the epithelial separation level would be at the basement membrane rather than intraepithelial like in pemphigus vulgaris. There is also no acantholysis like in pemphigus vulgaris. Direct immunofluorescence would show a linear distribution of the IgG and C3 localized at the basement membrane as well. Clinically, sometimes there may be blood blisters. This is sort of a characteristic feature that occurs because of bleeding into the intact bullae. The treatment is usually topical steroids, but systemic steroids may be required, particularly if there is ocular involvement. In some refractory cases, then medications like azathioprine may be added to the steroid as well. Another vesiculobullous disorder is the bullous pemphigoid, which affects patients above the age of 60 years. It's uncommon to have oral manifestation for the disorders, only in about 16% of the cases. It leaves multiple discrete vesicle formations, similar to pemphigus vulgaris lesions, but less painful and also smaller in size. It can also cause desquamative gingivitis, and it does not affect the lips as much as their affection in, for example, pemphigus vulgaris. It's self-limiting, and also has early remissions. It is being reported in conjunction with other diseases like multiple sclerosis or malignancies, or with the use of certain medications, particularly diuretics. The treatment is topical steroids in the management of the localized oral lesions, but extensive lesions would require systemic steroids either alone or in combination with immunosuppressive drugs as well. Another autoimmune subepithelial mucocutaneous disease is the linear IgA dermatitis, which affects mainly females. It can affect both adults and children, with the peak incidence at the 6th or the 7th decade of life. It affects mostly the palate, hard and soft palate, tonsillar areas, and the buccal mucosa, and can also cause desquamative gingivitis. The lesions are very similar to mucous membrane pemphigoid, forming vesicles that rupture and leaves about painful ulcerations and erosions, plus the desquamative gingivitis. They are usually managed by topical steroids, but sometimes dapsone therapy for the more severe cases is recommended, or systemic corticosteroids in very resistant cases. And finally, the angina bullosa hemorrhagica. This presents with a blood-filled bullae on the soft palate or on the cheeks mucosa. The bullae arise rapidly, often as a result of minimal trauma like eating, for example. Patients can become very alarmed with this bullae and have a choking sensation. They may rupture to drain all the blood and leave about a painful ulcer. The disease is seen more in patients who are using steroid inhalers with a poor technique, leading to deposition of high doses of steroids on the soft palate or the buccal mucosa. This would lead to mucosal atrophy and capillary fragility, and this would initiate the bleeding into the vesicles. These patients would be instructed on a better inhaler technique and asked to mouthwash and gurgle after using the steroid inhaler.
By this, we come to the end of this presentation on the diagnostic algorithm for oral ulcers. Assalamu alaikum.